Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by Mark Drugs, who specialise in the custom compounding of medications, assuring that the client gets the proper prescriptions for their unique needs and conditions. They work with practitioners, integrating knowledge and treatment of experts to create comprehensive health plans. Visit markdrugs.com or call Roselle 630 529 3400 or Deerfield 847 419 9898. Today my guest is Dr. Lester Lee, who's from California. Thank you for joining me today, Lester.
Thank you very much. Appreciate being here. Thank you.
Well, can you tell us who you are, what you do, where you're from?
Again, yes, my name is Lester Lee. I'm a physician, MD, in Huntington Beach, Newport Beach, California. My training is internal medicine from the University of California, Davis, and fellowship training in sports medicine, as well as functional integrative medicine with additional training. My practice focuses on functional medicine, people who have hormone replacement deficiencies, as well as autoimmune disorders that are related to the functional integrative component of why they present to the office.
Mm-hmm. And when did you first hear about LDN?
About 15 years ago. Piqued my interest. My background is in pharmacy. I went to pharmacy school back 75 to 78, the PharmD program. I didn't ever practice pharmacy, but I learned about it at that time, of course, much more at an experimental level, because that was back, in the mid-late 70s. My interest came with working with patients who were not getting response from their rheumatologist for autoimmune disorders, looking further into it in much of some of the European studies, as well as here in the U.S. I think Dr. Badaria and another individual, I can't remember all the different researchers' names, but I started trying in patients who had failed the injectable biologics, who have maybe rotated to different biologics with their rheumatologist because of failure to respond to one medication, or they built a tolerance. So my thought was, what the heck? These individuals are very desperate. They're in pain. They're tired. They're sick and tired, and the quality of life is just extremely poor. So the low-dose Naltrexone, I thought, why not? It's worth a try, and I was getting fabulous results with a limited number of patients originally, a number of years ago. The practice has a fair number over the last 10 years, who I do place who are appropriate candidates on the LDN. And the doses range from 1.5 to, even 7 milligrams. So my experience came as a result of frustrated patients spending a lot of money here in the States, especially if their insurance companies did not cover that biologic item that the rheumatologist chose, or oncologist. Then I said, you know what, this is pretty expensive. The difficulty is finding a reliable, consistent compounding pharmacy to make the Naltrexone 1.5, 3, 4.5, 7, what have you, milligram capsules. And I was fortunate to find a pharmacy called Blue Coast Pharmacy right here in Orange County, in Huntington Beach, as a matter of fact. And they do an excellent job, and they mail the medication anywhere in the United States for no additional cost, and it's fairly inexpensive, too.
Mm-hmm. So you mentioned hormone replacement, and you mentioned oncology there. What other patients, do you treat? What conditions, rather, that the patients present with?
The focus of my practice and reputation is hormone replacement therapy. I introduced it, frontiered it to Orange County back in '85 when I started practicing private medicine. And a number of the patients, again, conventional medicine is disease-oriented. My practice is proactive, functional, as I said. Individual has blood pressure, weight issues, diabetes. We try to work with the causation of those rather than just giving them commercialized medicine to control the blood pressure, to control the diabetes, the sugar. Along with those maladies, of course, comes the coronary disease, excuse me, the quality of life issues, the weight gain, the cognition, memory. They all tend to diminish or decay depending on the individual as they mature. So my patients find their way here because, again, they've been frustrated with conventional medicine of treatment, both 50-50, men and women, in terms of the patients that we see here. The practice is, of course, focused on hormone replacement optimization, women, estrogen, progesterone, testosterone, DHEA, pregnenolone, thyroid, adrenal support, growth hormone even, depending on which deficiencies and presentation of symptoms, depends on which protocols that I would place them on. Men similarly, but not quite as many different hormones. Along that, we also find that a fair number of people who have been to their primary carers, conventional medicine, were told their thyroid was normal. Well, if it wasn't adequately evaluated completely, a free T3, free T4, besides a TSH, a reverse T3, an iodine level, a little more complete study of their thyroid, we find out that they are clinically low in thyroid and symptomatically low. We place them on compounded thyroid sometimes, T4, T3 combination, and they get remarkable results. Like the lights were turned on, the cognition, the memory clears up within 2 or 3 weeks sometimes, even a shorter period of time. The weight starts coming off. The vitality comes back. The belly fat starts decreasing. Motivation is increased. Similarly with cortisol support. If we replace the cortisol because chronic stress, duress, physical, psycho-emotional, their adrenals start becoming depleted. We give them a plant-based adaptogen, sometimes all they need, to help with cortisol support during the day when it's highest and when they need it. And again, the fatigue issues resolve fairly rapidly within the first 2 weeks a lot of times. And of course, cortisol adequacy is needed for optimization of thyroid support, conversion of T4 to T3, the active form of thyroid T3 with 3 iodine molecules. And most physicians in conventional medicine don't address that. If you look like you're in normal range, which is a wide range, thyroid, you're normal. And cortisol, they really don't address that very much. Myself being a past 88, 92 Olympic team physician for U.S. for track and field, there are a fair number of athletes, intense training athletes, who are clinically adrenal insufficient and thyroid insufficient. Remarkably, again, you place these individuals, optimize those glandular products, they remarkably do well in their performance, the training, motivation, peaking at their goals. So the hormone part is just part of the practice. Heavy metal evaluations, detoxifications, neurotransmitters from the brain, salivary cortisol testing, organic acid testing. So it's not just the hormones, but when a patient comes in, male or female, of course, we addressed looking at the symptoms that helps me determine where the problem is. Is it coming from the hormones, the thyroids, the adrenals? Is it coming from some kind of toxicity, environmental, chemical, non-chemical toxicity? So the whole picture is it autoimmune? So that's part of it. And synergistically, if we work with, say, the autoimmune component, let's say the LDN component, and we complement and optimize the other aspects of thyroid, adrenals, transmitters in the brain for cognition, mood swings, these individuals are remarkably have a turnaround, a new lease on life, the best way to describe it.
I'm surprised when you said your practice was 50-50. It would seem to me, the people that I speak to, women have more issues than men with autoimmune conditions. So it's quite good that the men must be speaking up in your area and seeking help, which is always a good thing. When you start people on LDN into the protocol that you do for people that have an issue with their thyroid, do you pay particular attention? Do you find that they then have to take less of the thyroid medication?
That's a very good question. That was one of my observations 10, 12 years ago. Individuals, positive thyroid antibodies, let's say they're Hashimoto's, they're inflamed, they're chronically inflamed. We're trying to modulate that inflammatory process. Placing them on LDN after a couple, 3 months, I do notice that they respond much more positively, almost like a positive modulation of the thyroid medication. In terms of the dosage, they're a fair number. Yes, we've been able to not completely take them off, but decrease the dosage or the frequency. If they were on, say, twice a day, they got back by with maybe once a day. And once we control the inflammatory markers and the inflammation, again, the other components of their metabolism have changed, and for the better.
Mm-hmm. And I know there will be people out there listening and saying, wow, 7 milligrams of LDN, because a lot of patients only go up to 4.5. There are doctors out there who will prescribe it as high as 12. Could you explain to us how you titrate a patient up to 7 milligrams?
I usually start at, depending on the patient and diagnosis, between 1 and 1.5 milligrams, let's say at bedtime. Mm-hmm. I'll have them on that dosage, and if there's no ill-toward adverse response or reactions, I'll bump them to 3, probably within the 2nd or even 4th week. If they are fine, let's say at 3, control of pain, quality of sleep, insomnia resolves, they feel subjectively they're getting better, I'll just leave them at 3 milligrams. I don't tend to have a number of patients on 4.5. For my practice, it seems like 3 is a magic number. Mm-hmm. At 4.5, there are a fair number of people who may have some very vivid dreams, if not nightmares, if we want to call them that. And their quality of sleep sometimes, of course, is going to be disrupted. In those individuals who said, you know what, I do get a better response at 4.5, but it's hard for me to sleep because I have these odd dreams, I'll even split the dosage. Let's say, why don't we do this? Let's go ahead and have 1.5 milligrams in the morning, 3 milligrams at bedtime. And a number of patients, I don't have a tremendous amount of patients with a split dose like that, but they seem that it resolves that adverse part of the problem with, let's say, vivid dreams or accentuation of the insomnia. Mm-hmm. Or even nausea. I believe I have had maybe just 1 or 2 patients over the last 5 years said, you know, at 4.5 milligrams, I get a little nauseated. So if I split the dosage up, it seems to be a little more receptive and agreeable to the patient. Mm-hmm. I haven't reviewed a ton of the literature in regards to at a higher dosage, let's say, is split dosage a better response than all at once at bedtime, mm-hmm. or even daytime. But my understanding, reviewing the literature from many years ago, bedtime seems the most common sequence to take the medication. So, of course, I follow that too, but during the years that transpired, a number of patients said, you know, I did pretty well on split dosage. Mm-hmm. Instead of taking 5 milligrams, 3 milligrams all at bedtime, I took 1.5 twice a day. And I think I slept better, and I still had a good response. Well, I'm not sure how many number of the other listeners have had that kind of experience either.
Yeah, some people do that. There are many now that prefer to take it in the morning, and they get mm-hmm. just as good benefits rather than taking it at night. But the question I'm always being asked is, how do I know if the dose is right for me, and how do I know how high I can go up to? Would you like to have a go at answering that?
Yes. The question comes up many times when we're starting a patient. Well, one, how do I know when I need a higher dosage? And two, well, how long should I stay on it? So again, the titration, again, my usual is about that 1.5 milligram magic number. And once I get to about 4.5, if I don't see much of a response after a couple months and they've been on that, let's say 4.5, which seems to be an average top number for most practitioners that I've spoken to, I don't seem to go higher, but in some cases where they may be on a biologic at the same time simultaneously, let's say at 4.5, I said, why don't we do this? Well, let's go ahead and take another 1.5 in the morning and take your 4.5 for the next 2 to 3 weeks, 4 weeks, just to see if you feel subjectively you have a response. And two, if you're going to be seeing your rheumatologist, your autoimmune doctor, if you're going to be drawing blood, send me a copy. Let's look at the inflammatory markers. Let's see how they look compared to 6 months ago or 3 months ago. So there isn't an exact answer, let's say, that I have for patients that how high can I go. I don't think I've ever gone higher than 7. I'm aware that there are some other practitioners who've gone 10, 12. Again, I don't have that experience in those higher digits, especially in double digits. Not opposed to it. My other thought is if I were to, and let's say in a myelodegenerative, an MS, a Lou Gehrig's type patient, and let's say we're already at 4.5. Well, I think I may do a split dosage. Let's try. I don't think there's going to be any adverse reaction other than maybe some nightmares that you might have. But let's go ahead and try 4.5 in the morning, 4.5 at night. And you let me know if, one, if you can't tolerate it for whatever reason, and after a month, let's say, if you feel there's any change. Of course, it may take 3, 4, 5 months before they notice any kind of response, depending on the severity of their autoimmune disorder, whether it be severe rheumatoid, lupus, MS. I've had a patient who responded, I believe he was a 7 milligram dose, split dose, was polyarteritis nodosa. And actually another patient, currently I'm trying at 6 milligrams, polymyositis. And he's had this diagnosis for 4 years now and has multiple rounds of biologic injections. And they're starting to, as he said, they're wearing off. They're not helping me. All I have is side effects. So 3 months ago, I started him at 1.5, escalated his dosage to 4.5 very rapidly over about maybe 6 to 8 weeks. And currently he's now, as of last week, 6 milligrams. So I'll wait for a response on how he's doing. He's due for another round of a different biologic with his rheumatologist and neurologist. But I said, well, let's see if this works, if it really does help you. Mm-hmm. So I'm waiting for that to come October to see what kind of response that we have with the new dosage.
Mm-hmm. And people will always ask as well, how long will I know if LDN is working for me? What sort of time frame do you give your patients?
I usually tell them, well, you may notice something very rapidly, like aches and pains and insomnia within the first couple weeks. But it depends on the dosage. I normally tell them, you know what, give it a trial at least 3 months. It may take you 4, but give it at least 3, depending on the diagnosis, the number of years they've had that diagnosis, and the severity of the diagnosis. I also notice that those individuals who have short remission periods and their flares are more frequent, and not just frequent but intense. These individuals up to 6 months before they had a response on the LDN. Mm-hmm. Now, is it coincidental that they may have been going into remission anyway 6 months later, or is it the LDN? I'll let them know that that part I can't answer, but either way, you're mostly symptom-free. Mm. So is it the LDN? Continue it, assuming there's no ill-toward reaction to, let's say, the 4.5, 6 milligram, 7 milligram.
Mm-hmm. So what age ranges are your patients?
Let's see. The youngest, I believe, is probably about 23, and she is a Hashimoto's patient. And the more senior patient I have would probably be about 82, and that's an MS patient.
And in your patients of advancing years, should we say, have you come across dementia or any memory loss problems or Parkinson's?
You mean treating
Yes.
with LDN or?
Yes, treating with LDN.
Parkinson's, I would say 1.
Oh, right.
And that was a year ago. And have him up to 4.5 over about maybe 6-8 month period. I would say that his Parkinson's, and he feels, is not progressing. And his tremor and cognition, he feels, at least subjectively, and with his neurologist, is better after about 8 months. But again, it's not a significant change, but it's a positive one, and he feels he's not progressing. Especially if concerned not just the motor, but the cognition is a major for anybody, that if I completely lose my mind, then it's not worth living at all. So his thought is, regardless if it's helping, which it should, the motor function, but if I can retard the process, not necessarily reverse it, but retard it, and keep his faculties, his cognitions intact, that would be his goal.
But it's
and he would be on it forever, he said, if that's how he feels month after month.
Oh, good. But it's the same, isn't it, with any progressive disease? If all it does is halt the progression, you're winning. It's working.
Yes.
I've found over the years there are many people who will say, even like 18 months after being on LDN, that it hasn't actually helped with symptom relief. It's only helped to stop progression, which they're very happy with.
Yes.
But we did a survey a long time ago now, but it was in between 15 and 18 months, and I have no idea why, after having taken it so long, that they started to get symptom relief after such a long period of time, where you would think if they were going to get symptom relief, they would have received it a lot sooner.
Yeah, correct. And the patients who didn't receive any feeling of relief after 6 to 8 months, they tend to stop on their own. And on follow-up, let's say, on the whole, I don't see my patients but every 3 to 6 months, especially the hormone patients. I only see them twice a year once they're dialed in and optimized. It's not like I have a tremendous autoimmune Parkinson's type practice. If they present, actually, how they're presenting is they are coming in, they may already have diagnosed an autoimmune elsewhere, may have been treated elsewhere for a number of years, but the hormone component is why they're presenting. If they do, I'll discuss, have you ever heard of LDN? Google it. It's not the high-dose stuff we use for opiate overdose. So Google it. Here's some information, some literature. Here's a site. If you think it's appropriate, I'll get you a script. Try it out for the next 2 months. It's not that expensive. It's like maybe $1, $1.15 a capsule. Blue Coast Pharmacy, again, here in Huntington Beach, California, they're very reasonably priced. They're consistent on their compounding. They mail anywhere in the United States. So a fair number of them will say, yeah, you know what, why not? But again, creatures of habit wanting immediate gratification, after, say, 6 months, 8 months, they say, well, I don't notice anything. I said, well, that part I can't answer when you will get a response, when you will feel, whether it be subjectively or objectively. Now, a number of times when we place a patient on, and I'm getting a fresh set of labs, let's say they've been on 6 months. I don't feel much difference. Maybe, but I'm not sure. We obtain lab markers, inflammatory markers. So guess what? This is how you were a year ago. They were really high. They've come down by 30, 40, 50%. So what does that mean? Well, it means you're less inflamed, so theoretically, cause and effect relationship, you should be feeling better. He said, okay. So interestingly, that placebo effect is a strong motivator and a strong healer. If your lab's looking better, I should feel better. And there are a number of patients who said, well, I guess I do feel better. Okay, all right. If it's working, it's working. But if we're showing them objective evidence that something has changed for the better, I've had a few patients say, well, you know what? Yeah, you're right. I think I am feeling better. I was under more stress, so maybe it was the stress, or maybe it was the loss of the job, or maybe it was this the change in a lifestyle, a change in marital status, a change in financial status, moving to a different state or a country. Perhaps that stressor alone induced a flare, or it was just the stress of that, and they couldn't tell the difference if they're getting better, or was it just the change in the stressor, whether it be psycho, emotional, physical.
Have you found any of your patients who have thought LDN wasn't doing anything for them and stopped and then realised LDN actually was doing something and restarted?
Yes, a fair number. That's a very good question. Again, back to I was commenting about objective evidence, your labs are getting better, these individuals stop. Yes, they all of a sudden realize, you know what? Boy, within a couple weeks, less than, my pain came back, and therefore I couldn't sleep, or I felt swollen and puffy. So, I guess I was. So a number of times I'll just tell a patient, if you can't really tell if you're getting better, go ahead and stop it for a week. See if you feel any different. Mm-hmm. And a fair number of patients have said, yeah, you know what? I'm not sure if it's in my mind, but I guess I was a lot better. So I'm going to go back on it. I said, okay.
Mm-hmm. Well, it's
that's
good.
A very good observation, a very good question observation, because how do we know it's helping sometimes till you stop it?
Exactly. But I think it's good in your practice that you are not only looking for root causes, but to try and prevent conditions happening in the first place, which is, it's got to be a really good idea. And how soon can a patient get to see you? Do you have a waiting list?
Actually, I do not. I have, aside from myself, 2 other full-time practitioners. So we can normally accommodate you in less than a week. Mm-hmm. In fact, most cases within 48 hours. Okay. We take our time. We spend anywhere from 30 minutes to an hour with a patient on initial consultations, because a fair number of them have a very complicated history. And especially if we're concerned, is your flare, your autoimmune, initiated by toxic exposure, heavy metal exposure, chemical, non-chemical. Oh, just had a lady last 2 weeks ago, her silicone breast implants. 2 years ago, she was perfectly fine, received the silicone implants, and was diagnosed autoimmune. And she just recently, 3 weeks ago, had them removed, and the surgeon said that, gee, you're really inflamed, your tissue's inflamed. We do urine testing for plastics, phthalates, benzenes, a panel of chemical, non-chemical exposure, and she was positive for 8 items in chemicals having to do with plastics. Mm-hmm. So her diagnosis, her autoimmune was triggered by a chemical exposure, from all things, and intact silicone implants.
Now, it's funny you should say that. In the last year, I've had, must be 3 people who have told me of a similar thing, that they were absolutely fine until they had breast implants, and that triggered an autoimmune condition.
Right.
Do we always know what it is we're putting in our bodies, Makes you wonder.
No, we don't. And how do we know that we're going to be reactive?
Yes.
Just like the foods, the healthy foods we eat, whether it be kale, cruciferous vegetables, ginger, soy, healthy fish and salmon. And when Dr. Singler, I believe she spoke on your show a few months back,
yes.
They eat very healthy. They don't eat egg yolks. They eat egg white because it's healthy. It's the gold standard for protein. The yolk has cholesterol. That's where the fat is. We do a food hypersensitivity panel on them of 350, 60 items. 50, 60 things come up in the highly reactive columns. And, I eat every one of those, and they're all healthy. I agree. From kale to broccoli to sauerkraut to bananas. And guess what? Eliminate all 50 of these items in your diet. See how you feel in the next 2 weeks. Amazingly, again. Cognition better, skin quality, fatigue, lights turn on again. They feel so much better. Again, can these be triggers just from food? Not gluten, not celiac, but say just certain foods creating reaction, inflammation, trigger an autoimmune component.
It worries
me. So we're looking
at
the root causes again of finding where is the trigger coming from. The trigger for weight gain, because you're chronically inflamed. You're chronically inflamed, it's hard to lose weight. If you're estrogen dominant, and it's hard to lose weight. So we put them on DIM, we put them on indole 3-cannabinol, we put them on even saw palmetto to, say, lower the estrogen, and they feel better. They lose weight more readily. Their breasts aren't swollen. They're not puffy. They're not retaining as much water. The cycles aren't as heavy. Their endometriosis isn't bad. So again, we're looking not just hormone replacement therapy, but if I come across, and my doctors come across, there are other components of why you're inflamed that can relate to your autoimmune. Your MTFHR DNA mutation gene is positive 2 copies. Things like that we bring into the picture. And the whole global picture, again, is you're inflamed. But let's find out the reason why. And you have an autoimmune. It's genetics. But you're the only person that has it in your family. So let's see if there was some kind of a trigger that caused it. So that's how my practice works. They didn't come here because of the autoimmune. We may discover the autoimmune. We may be hoping to find a resolution, a mitigating factor, the root cause of the autoimmune. And then LDN is one of the components that we may work with helping with the symptoms of the autoimmune.
Well, we've now run out of time. It was very interesting talking to you. You've got so much to say. It's really interesting.
My apologies for running on. I know there was only going to be half an hour. didn't mean to squeeze in that much information in a short period of time.
Well, we'll have to have you back another time, and thank you for having been our guest today.
Well, thank you very much.
This show is sponsored by Mark Drugs, who specialise in the custom compounding of medications, assuring that the client gets the proper prescriptions for their unique needs and conditions. They work with practitioners, integrating knowledge and treatment of experts to create comprehensive health plans. Visit markdrugs.com or call Roselle 630 529 3400 or Deerfield 847 419 9898. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.